Tom, it's a pleasure to see you and to meet you, at least virtually. You did give us an abstract with the title Association between short-term systolic blood pressure variability and functional outcome after acute intercerebral hemorrhage, an analysis of pooled individual participant data. May I ask you, what is the background of this research question?
Very nice to meet you as well, Professor Steiner. And it's great to be speaking with you today about this work. And the background for this research is really around the persisting uncertainties about how we best manage blood pressure after acute intercerebral hemorrhage. We know from a recent update to European Stroke Organization guidelines that it's recommended that we do lower blood pressure early after the onset of acute intercerebral hemorrhage, particularly within 6 hours of onset, where there's evidence of an effect of treatment on reducing the odds of hematoma expansion and probably improving functional outcome as well, although there's some controversy over that. But there's still some uncertainties here, particularly with the approach to treatment thresholds, etc. And one aspect of our approach to treatment, and one issue that really inspired this research, is around the issue of variability. We know our patients' blood pressure fluctuates when we start treatment, some more than others. And in acute intercerebral hemorrhage, perhaps large peaks in systolic blood pressure may contribute to more hematoma growth, more perihematomal edema formation, and troughs cause concern when it comes to end organ ischemia, particularly within the brain. So we set out to try and understand these issues in acute intercerebral hemorrhage, and that was the real aim of this project.
Can you say something about the studies you included?
Yeah. So I was very fortunate to work with an international collaboration here, convened by Professor Philip Bath from the University of Nottingham, and the ICH component also led by Professor Craig Anderson too. And we were able to pool individual patient data from 16 randomized control trials that participated in the blood pressure in acute stroke collaboration. And these were a broad range of trials that tested various different agents and strategies that affected blood pressure after acute ICH. And we used patient-level data, particularly the blood pressure data that was collected after randomization, to assess associations between variability, which we defined as the standard deviation of measurements of systolic blood pressure, against functional outcome, primary outcome being function on the modified ranking scale, with a shift towards worse outcome being our point of interest there. So we analysed the association there to try and see if the more blood pressure variability was associated with poorer outcomes.
Mm-hmm. Yes, very interesting, very relevant. So Tom, please tell us a little bit about the results.
Okay, so we got data from over 6,000 patients from 16 randomized controlled trials. And we found that for every 10 millimeter mercury increase in the standard deviation of systolic blood pressure during the first 24 hours of treatment, there was a corresponding 20% increase in the odds of a poorer functional outcome at 90 days after acute ICH. So simply higher blood pressure variability being worse for outcomes at 90 days. We also tested interactions according to the approach that was taken in the trials. And we found the association was stronger amongst patients who had more intensive titrated blood pressure lowering treatment, predominantly with intravenous alpha and beta adrenoreceptor blockers and intravenous calcium channel blockers too. So there's some interesting findings there that perhaps we could interpret a little bit as we discuss further.
Yeah. So what do you think, what is the impact of the study in clinical routine?
So I think if we take the results in the context of the randomized controlled trial evidence that's been presented before, and also take it in context with the recent European Stroke Organization guidelines, which suggest that clinicians do lower blood pressure intensively early after the onset of ICH. These results showed strong associations between variability in blood pressure for those patients and poorer outcome, which makes us pause for thought when we do lower blood pressure intensively. Maybe we should do it carefully, perhaps trying to avoid large fluctuations in blood pressure and really achieving a sustained control if we can over that first 24 hours of treatment.
Okay, but how does that affect the initial speed of starting the treatment? How soon should we start with a treatment and how low should we go?
I think probably slightly aside from this work, I think there's other evidence to suggest most hematoma growth occurs early. So I think there's good rationale for starting treatment earlier. The best evidence to show that blood pressure lowering reduces hematoma growth occurred in studies that randomized patients typically within a few hours of intracerebral hemorrhage onset, within 6 hours, but after the point of diagnosis. So I think we should be doing this early. Earlier is probably better. And then when we do initiate treatment early, trying to sustain reductions and reduce variability may also be important.
Yeah, talking about practical issues, we all know that the drugs we are currently using have a certain half-life time, and that makes it sometimes difficult to avoid, for example, an overshoot. So is there any recommendation or guideline you would like to tell us about how can we do this smoothly enough? Any suggestions?
I think that's a really tricky question, and we'd love to answer that question with the data that we had here in this fantastic data set, but that was challenging. I think the reason being is we know that patients respond differently, and the patients in this meta-analysis, over 6,000, received such broad interventions. Many patients received more than one agent. So to really be precise and say that one agent is better than others for variability based on these data is really quite challenging. I think that further research is needed to really determine which agents may be beneficial in achieving smooth control, but we don't have the answer yet to that one.
So that would mean we have large trials comparing one drug with the other?
I think for definitive evidence, I think that's the only way we generate such data, but we need probably some early work, some preliminary data to really test these hypotheses. And I think maybe just starting with simple strategies as we measure patients' blood pressure more. Now the paradigm has shifted for ICH. We tend to be more intensive with our measurements and our titrations. Perhaps these sort of approaches are more beneficial to achieving slow, sustained control, as opposed to maybe some of the older strategies to give a single medicine and walk away, or maybe use a single patch and walk away. I think that perhaps that more careful monitoring approach might be beneficial here. But again, we need research to tell us that that's true.
Okay, so you said you looked at the phase between hour 1 and hour 24.
That's correct.
What happened? Can you say anything about what happens after that?
Yes, we can comment on what happens after that. Although I didn't present these data for the presentation, I did some analyses of blood pressure variability in days 1 to 7. And again, there's a strong association between higher blood pressure variability and poorer functional outcome in days 1 to 7 after acute ICH. The challenges to the interpretation there is as you move forward out of that first 24-hour period to the first 7 days, is probably confounding by other medical issues that we know are frequent in our ICH patients, but still there is that suggestion that we should be careful and try and sustain any blood pressure reductions for 7 days if possible.
Tom, it was a pleasure talking to you. very interesting results. I think they have very important, will give us or have an important impact on clinical routine. Thank you very much.
Thank you, Professor Steiner. I'd also like to thank everyone involved in the collaboration and the very many patients that provided data for this important study. So thank you.